A very good evening, everyone. Am I audible? Hello? Am I audible? Hello? Am I audible, ma'am?
Yes, now you are. Yeah.
It gives us immense pleasure to welcome you. Hope you are doing well in this unprecedented pandemic.
Yeah. I'm doing well.
So today, honorable guest lecturer is Rachel Natasha, MD, Department of Psychiatry, Malmodens Medical Center, Brooklyn, New York State Psychiatric Association's RFM representative. So she will teach us on biological therapies today. So hope you all will enjoy. I will request Dr. Rajeshi Niyogi to say a few words.
Yeah, sorry for the glitch. Okay, thank you, Rachel, for accepting the offer. I think it's about 6 o'clock New York time, early in the morning.
No, it's actually 12 in the afternoon. So
Oh, okay, 12 in the afternoon. So it's fine. So thank you for making time for CAB, and thank you for picking up this very important topic of biological therapies. We will be wiser today, I think, with your deliberations. And without much ado, I'll like you to sort of proceed with your slides and presentations. Thank you.
Okay, thank you. Thank you all for inviting me and giving me the opportunity to present. I'm just going to share my screen. Okay. Are you able to see my screen?
Yes, ma'am. Yes.
Oh, okay, great. Okay, so today I'm going to be talking about biological therapies in psychiatry. It's quite a vast topic, but it's really interesting, and I hope you all find something useful from it. Briefly, I'm a fourth-year psychiatry resident. I'm a chief resident at Maimonides Medical Center in Brooklyn, New York, and I'm very honored to be here to present. So essentially, when we think of biological therapies, it's quite an umbrella definition, and it basically includes any form of treatment for mental disorders that attempts to alter the physiological functioning of the brain. So that can include drug therapies, electroconvulsive therapy, and psychosurgery. In this lecture, I'm predominantly going to focus on drug therapies and briefly speak about electroconvulsive therapy and other forms of treatment, newer forms of treatment. Okay, so the objectives of this lecture is going to understand the indication for different classes of psychiatric medications, along with understanding the mechanism of action and adverse effects for these different classes, and also to briefly understand ECT and psychosurgery. The first part of my lecture, I'm going to be speaking about psychiatric medications. Briefly, the classes of medications that I'm going to go over are antipsychotics, antidepressants, mood stabilizers, anxiolytics, stimulants. So antipsychotics, I thought I'd include a little bit of history. Basically, somewhere in the 1960s, there was this French naval surgeon called Henry Laborie, and he was studying promethazine, which, as you all know, is an antihistamine. And he was studying it to see its effects on the autonomic nervous system, especially for circulatory shock. When he was testing it on different people, he saw that some of its effects were that it was making people feel drowsy, it was reducing their pain, and it was creating this feeling of quote unquote euphoric quietude. So they found this quite interesting, and then they decided to study promethazine a little bit more. His observations with promethazine is what helped to create the first antipsychotic medication, which is chlorpromazine or thorazine, which is basically a metabolite of promethazine. Prior to this, there were different treatments that we used to treat psychosis. Some of this includes music therapy, shock therapy, and some are a little more brutal and almost barbaric ways of treatment. They used to do phlebotomy, which was essentially cutting off a part of the frontal lobe. They used insulin shock therapy, which was basically where they would inject patients with insulin and induce a hypoglycemic coma in them. And finally, there would be institutionalization, and essentially they would just kind of keep mentally ill patients away from the rest of society. We've come a long way since then. And even though, the prevalence of schizophrenia is 1 in 100, it sounds small, but that's actually quite a significant number of people affected by schizophrenia. Age of onset is usually in early 20s. Till now, we don't fully understand what causes schizophrenia, but some theories are that it's triggered by stress or illness. There's also the genetic predisposition theory, which states that if somebody has a genetic loading for schizophrenia, then they have a higher potential to eventually get diagnosed with schizophrenia in periods of stress. To briefly touch upon the different symptoms that schizophrenia can present with, you have your positive symptoms, which are usually caused by increase in dopamine. So that's hallucinations, delusions, disorganized thought process, perceptual disturbances, inappropriate emotions. So anything with excessive dopamine that's positive, like it's something that you can actually elicit. Negative symptoms means the lack of something. So that's usually by decrease in NMDA. That you could see as blunted emotions, anhedonia, lack of feeling. So a lot of times it almost looks like autism spectrum, like blunted emotions, anhedonia, lack of feeling. The third and the fourth cluster of symptoms is cognition deficit. So they have trouble with new learning, with memory. And a lot of patients with schizophrenia also have mood symptoms, loss of motivation, social withdrawal, insight, demoralization, and suicide. So as you can see, there are many complex symptoms that's going on in schizophrenia, and the treatment for it is still ongoing. So like I said, the positive symptoms include these thought disorder, delusions, hallucinations, and negative symptoms is what's mentioned on the slide. And the reason I've clustered it like this is because the treatments help to treat these clusters of symptoms based on the neurotransmitters that they act on. It's also important to understand 3 hypotheses for schizophrenia. There's the dopamine hypothesis, which basically states that excessive dopamine in the brain is what causes schizophrenia. There's the serotonin hypothesis, which says that the serotonin dysregulation in the brain is what causes schizophrenia. And the glutamate hypothesis, which states that because of NMDA blockade, there's what causes the negative symptoms of schizophrenia. So in the past, they used these different hypotheses to treat schizophrenia. So past studies showed that because of excessive dopaminergic activity, that was causing the positive symptoms. And because of that, how do you treat the positive symptoms of increased dopaminergic activity? You block the dopamine. So the treatment for that was dopamine antagonists. Right now, there's a renewed interest in serotonin being the cause for schizophrenia. So how do you treat that? You combine the action of serotonin antagonists along with dopamine antagonists. And in the future, we predict that there's going to be more studies on NMDA, which causes the imbalance in the cortical communication and cortical midbrain integration. So future studies will possibly include more studies on NMDA agonists, selective antagonists, mixed agonist-antagonist analogs, and neuropeptide analogs. If we look more closely at the different dopaminergic pathways in the brain, there are essentially 4. So there's the mesocortical, there's the mesolimbic, there's the tuberoinfundibular, and the nigrostriatal. And in the next slide, you'll see what each of these pathways essentially do. So you have the mesolimbic and the mesocortical. And if you think of it this way, it's kind of in the front part of your brain. That's for emotional and intellectual processing. And the antipsychotic effect that acts on these dopamine pathways is what's responsible for helping in treatment of delusions, hallucinations, and disordered cognition. So it acts over there. Then the nigrostriatal pathway is essentially in the basal ganglia. So that's where once the antipsychotic acts on that pathway, it causes the EPS, or the extrapyramidal, the neurological side effects of antipsychotics. And the tuberoinfundibular pathway is what innervates the pituitary gland, and that's what regulates endocrine functions. So with long-term effects of antipsychotics, when they start blocking those pathways, you'll see galactorrhea, elevated prolactin levels. If we have a closer look at antipsychotics, you have your first generation antipsychotics and your second generation antipsychotics. First generation antipsychotics, they're called first generation because they were first invented. You can classify them based on the chemical structure, or you could classify them based on potency. If you look at chemical structure, you have your phenothiazines, your B-tyrophenones, thioxanthines, and other heterocyclics. And under each of these classes, you have the different names of antipsychotics. If you look at the colors, the blue colored antipsychotics are low potency. The green are medium potency, that's perfenazine. And the red are the high potency, so that's haloperidol, trifluperazine, fluphenazine, and pymoside. Of course, the more commonly used antipsychotics are haloperidol, fluphenazine, perfenazine, chlorpromazine. First generation antipsychotics. Now, if you think about what I was telling you about dopamine blockade, these are very strong D2 blockers. So these are more effective in treating the positive symptoms. But what happens if there's too much D2 blockade? It starts affecting the different pathways in the brain. So this is the reason why first generation antipsychotics cause more of the EPS type of symptoms. So your tremors, your rigidity, your drug-induced Parkinsonism is more common with first generation antipsychotics. So if you look at the side effects, you can again classify it based on the receptor that it blocks. So you have your D2 receptor blockade, which again, I spoke about how it blocks those different pathways in the brain. That's what's responsible for the extrapyramidal movement disorders. It's also responsible for endocrine changes because of the pituitary, the tuberoinfundibular blockade, and sexual dysfunction for the same reason. You have your H1, so your antipsychotics, they block D2 predominantly, but it also blocks other receptors. It blocks your histamine receptors, and that's what's responsible for the sedation, drowsiness, weight gain, and hypotension. If you remember what I told you about promethazine, which was the precursor to chlorpromazine, that's an antihistamine. So that's how you can remember that these first generations cause H1 blockade. You have your alpha receptor blockade, which is what's responsible for all the autonomic instability that you may see with antipsychotics, and your muscarinic receptor blockade, which is what causes, the dry mouth, all the dryness, dry mouth, urinary retention, constipation, and in addition to that, the blurred vision, the sinus tachycardia, and your memory dysfunction. Let's take a closer look at the neurological side effects of antipsychotics. So like I mentioned, it causes EPS. But EPS is such a broad term. So the different things that it can cause are acute dystonia, akathisia, and Parkinsonism. Acute dystonia, and all these, like I said, it's because of the nigrostriatal pathway. So acute dystonia is essentially a spasm of any muscle. So if you see your patient, they might suddenly have like a twisting motion of the neck or a sudden spasm in a certain part of their body. Usually you'll see this pretty quickly, like within the first to fifth day of initiation of an antipsychotic. Again, the exact mechanism is not known, but it's postulated that it's because of the nigrostriatal block. The treatment of acute dystonia is usually something like diphenhydramine or promethazine. The next side effect is akathisia. It's basically restlessness. If you see a patient with akathisia, what they're going to describe it as is the inability to sit still. It's a very uncomfortable feeling. So they'll want to sit up and keep walking back and forth, like it's a lot of restlessness. The treatment for this is usually you can reduce the antipsychotic and see if there's any improvement. You could try an anti-Parkinsonian agent, or you could try benzodiazepines or propranolol to kind of calm that restlessness. And then the last one is Parkinsonism. So that's drug-induced Parkinsonism, which looks a lot like Parkinson's disease. But this presents with after the initiation of an antipsychotic. So you'll see your bradykinesia, which is your slow movements, rigidity, tremor, mask facies, shuffling gait. The mechanism for this is the antagonism of dopamine. And what can be helpful for this is anti-Parkinsonian agents. You could also try trihexyphenidyl or benztropine. Oftentimes, the most commonly used one is benztropine. You'll see a lot of patients who've been on haloperidol chronically who happen to be on benztropine as well for EPS. Some other reactions, you have your neuroleptic malignant syndrome. This is one of the emergencies in psychiatry because it can cause some severe effects. So it can cause stupor, fever, autonomic instability, myoglobinemia, and it can be fatal. This usually, it can happen immediately, but oftentimes it's seen after weeks of initiating an antipsychotic. The treatment for this is you must stop the antipsychotic immediately because it's life-threatening. You can also try dantrolene or bromocriptine to treat NMS. Usually anti-Parkinsonian agents are not helpful. Then you have your perioral tremor, which is a form of Parkinsonism. So you'll see tremor around the mouth. This happens after years of being on treatment. The treatment for this is anti-Parkinsonian agents. And then a very common one and something that you might get tested on is tardive dyskinesia, which is orofacial dyskinesia. So you'll see these lip smacking movements, these tongue rolling movements, and typically it's seen on patients who've been on first generation antipsychotics for many, many years. So they say it's because of an excessive function of dopamine. The treatment for tardive is you can stop the neuroleptic, or you could try a benzodiazepine. But what they found recently is that clozapine or olanzapine can be helpful in tardive dyskinesia. If you look at atypical, so we spoke about our typical antipsychotics, so the first generations, right? Like I'm going back to that slide where you see the names. Remember, first generation antipsychotics block mostly dopamine. Your second generation antipsychotics are your atypical antipsychotics. So these are your risperidone, quetiapine, olanzapine, clozapine, aripiprazole, amisulpride, ziprasidone, and other ones, lurasidone. Those are the most commonly used ones. With second generation antipsychotics, in addition to acting or being a dopamine blocker, they act on other parts, other neurotransmitters. So there's a lot of serotonergic effects, and there's alpha adrenergic effects and muscarinic effects, more than with your typical antipsychotics. So because they don't have as much dopamine blockade as first generation antipsychotics, you can see on this slide, the EPS is significantly less with atypical antipsychotics. However, the other side effects are more, like sedation, weight gain, hyperglycemia, anticholinergic effects, and orthostatic hypotension. So if you think about it this way, first generation causes EPS, second generation causes your metabolic syndrome, which is your predisposition for diabetes, hypertension. And you can see a comparison of these different medications and how they can cause the predisposition for these different side effects. I wanted to stress a little bit on clozapine. So clozapine is a second generation antipsychotic, but it is one of those medications that's proven to be very useful in treatment-resistant schizophrenia. And they think that the reason why clozapine is more effective than other second generation antipsychotics is because it has a stronger serotonin effect, and it has a stronger effect on the NMDA receptors. So remember how we spoke about negative symptoms being more serotonin and NMDA related? The first generations don't act on those receptors. So if a patient has negative symptoms of schizophrenia, they're unlikely to improve. The negative symptoms are unlikely to improve with first generations, but clozapine has shown to improve some of those symptoms. However, some things to keep in mind with clozapine is that it has some pretty severe side effects. You have to monitor blood very closely because one of the severe side effects is that it can cause agranulocytosis. The exact mechanism of action is not known, but they think that clozapine modulates one of the HLA genes that's used to code neutrophils. Clozapine titration quickly can precipitate seizures. It can also cause myocarditis. So you probably want to get a CBC, you want to get your liver function, a renal function, you want to get an ECG before you start clozapine because of the myocarditis. And the other side effects are because of its effects on your cholinergic system and your adrenergic system. So you look at the other common side effects, it's the sedation, the hypersalivation. That's one of, you'll see patients who have a lot of drooling with clozapine, tachycardia, hypotension, weight gain, constipation, urinary incontinence, fever. So that's briefly what antipsychotics. So to summarize, antipsychotics help in treatment of psychosis. Schizophrenia itself has 4 different types of clusters: your positive symptoms, negative symptoms, mood symptoms, and cognitive symptoms. Antipsychotics can be divided into first generation and second generation antipsychotics. First generation are more useful for positive symptoms. Second generation, while do help with positive symptoms, are more effective in negative symptoms. If you look at side effect profile, first generation causes EPS more commonly than others. Second generation is metabolic syndrome. In your second generation, you have your clozapine, which causes other side effects in addition to the metabolic syndrome, like agranulocytosis, seizures, hypersalivation, myocarditis. Now we can move on to the next class of psychiatric medications, a very commonly prescribed group, which is antidepressants. Antidepressants, the different classes of antidepressants, you have your SSRIs, your SNRIs, your MAOIs, TCAs, NDRIs, and tetracyclic antidepressants. I'm going to talk a little bit about each class of medications, but the first one that I wanted to talk about is your SSRIs, the selective serotonin reuptake inhibitor. This is the most commonly used antidepressant. It's the first line. So how do you assess for depression? When a patient comes into you and they report symptoms for more than 2 weeks, which includes, it has to include pervasive sad mood along with the other SIGI caps. Now, what is SIGI caps? S stands for suicidal ideation. I stands for decreased interest. G is guilt. E is energy, so low energy. C is concentration, so decreased concentration. A is decreased appetite. P is psychomotor retardation, and S is sadness. So if you remember that mnemonic SIGI caps, you need to have 5 of those symptoms in addition with sadness for more than 2 weeks. That's a major depressive episode. SSRIs are the first line for major depressive disorder. Commonly used SSRIs are citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, and dapaoxetine. Now, how do you choose out of these SSRIs, which one would you initiate a patient with? They all have the same mechanism of action, but if each one has a different side effect profile, so you choose something based on your patient's, based on your patient's demographic or what they prefer. Anecdotally, sertraline can cause a little bit more of the nausea, vomiting type of symptoms. Fluoxetine has a long half-life. So if you suspect that someone is more non-compliant than others, you might want to initiate with fluoxetine. So those are some things to keep in mind. But overall, SSRIs are very safe medications. They're the first line treatment for for depression. So this is the mechanism of action. So the name itself, it's quite self-explanatory. So it's selective serotonin reuptake inhibitor. So what it does is it acts on the receptor over here, where 5-HT. It modulates that receptor and it prevents it from getting reabsorbed by the neuron. So what happens is that serotonin kind of pools in the synapses, and so there's more serotonin in the brain. So again, the exact mechanism remains unclear, but they say that the human serotonin transporter is the determining factor in SSRI potency. Antidepressants interact directly with this human serotonin transporter. Like I said, SSRIs don't have severe side effects, but there are some things to be mindful of. There's a black box warning for children. So in adolescents and children, they say that after initiation of an SSRI, you need to be mindful of suicidal thoughts. So why is that? When I first read that, I was curious about why there would be higher incidence of suicidal ideation when you initiate an SSRI. And one of the reasons, or one of the theories, is that after you initiate, when a patient is very, very depressed, they don't have any energy to do anything. So even if they want to try to attempt suicide, they're too depressed to try. After the initiation of an SSRI, they might start having a little bit more motivation, more energy, but they're still extremely depressed. So that's one of the theories about why they have more energy to actually engage in suicidal behavior. But this is a skewed study because the sample size was very small, but there still exists a black box warning on SSRIs in adolescents. Another very common side effect of SSRIs is sexual side effects. So again, you might want to be mindful in young patients who have active sex lives, that it can cause two things: decreased libido, and it can cause anorgasmia. For men, it can cause erectile dysfunction. So it's very common with SSRIs. It's a 30% prevalence of sexual side effects. Some other side effects include nausea and vomiting. So you have GI side effects, but those are usually in the beginning. So when the patient is still developing tolerance to your SSRI, they might have some GI side effects. Some patients might complain of drowsiness, headache, dizziness, fatigue, but again, these symptoms usually are not pervasive. You'll see them when you initially start somebody on an SSRI, and they usually resolve. Bruxism, interestingly, I personally have never seen a patient have bruxism with SSRIs, but one of the mechanisms for that is because of the excessive serotonin effect. So if you read about MDMA, which is a party drug, people end up having bruxism, which is the involuntary grinding of their teeth. And that's because of the excessive serotonin and dopamine in the transmitters that is in your cervical spine area. So that's one of the reasons. Strange dreams, vivid dreams, again, anecdotally, you see it with patients, but it's not very distressing, not as distressing as some of the other side effects. But all in all, SSRIs are a safe medication to use. Like I said, a lot of side effects disappear within 4 weeks of starting the SSRI, which is called the adaptation phase. SSRIs have significantly lower side effects than other antidepressants like monoamine oxidase inhibitors and tricyclics. Sometimes patients might start feeling better and they might just stop taking the SSRI. That's called SSRI cessation syndrome. So they'll have like sudden recurrence of their depression. They might have some neurocognitive problems because of their depression reemerging. Usually, SSRIs take 4 to 6 weeks to start working. So if you have a patient who comes in and you start them on, say, sertraline, and they say they're feeling better in 2 days, that's most likely because of placebo. In 2 weeks, they might start seeing some difference, but to have full therapeutic effect, it takes 4 to 6 weeks. Usually for a major depressive episode, you want to keep the patient on the SSRI for 6 to 8 months and then slowly taper. You shouldn't really stop an SSRI abruptly. The reason is because they're more predisposed to having a recurrent episode. And once you've had one major depressive episode in your life, your potential to have more episodes increases. You want to try to prevent this for your patient. Now we have our SNRIs, which are your serotonin norepinephrine reuptake inhibitors. So these have a little more efficacy than SSRIs. And one of the reasons is that SSRIs act only on serotonin. These medications also act on norepinephrine. And what does norepinephrine do? It increases activation, increases energy, increases motivation. So for some people, they might prefer to start patients on an SNRI. If a patient is really depressed, not getting out of bed, has very low motivation, you might consider an SNRI. They also say that there are slightly fewer adverse effects than SSRIs, though it's quite comparable. The current SNRIs that are commonly used are venlafaxine, which is on the left of the slide, and duloxetine, which is on the right of the slide. They both, like I said, work on serotonin and norepinephrine. Side effects similar to SSRIs, again, the suicidal ideation after initiation is not because this causes the suicidal ideation, it's because the patient has pre-existing suicidal ideation and they start feeling more motivated, more energetic to act on their suicidal thoughts. One thing to keep in mind for duloxetine is sometimes patients who have a lot of somatic complaints. So if patients have arm pain or they have, say, fibromyalgia, duloxetine is a good medication to try with them because it can help with that. Duloxetine is also a good medication to try for restless leg syndrome. Then you have your norepinephrine dopamine reuptake inhibitors. The commonly used medication is bupropion. So now if we think of the antidepressants that we just went through SSRIs and SNRIs, which are your first line medication. If a patient is on an SSRI for 8 weeks and hasn't had any change, still feels very depressed, you could switch to another SSRI and give it a fair trial. If after 2 failed trials of an SSRI, you can try a bupropion. So bupropion, it's again self-explanatory. It acts on the norepinephrine and dopamine reuptake inhibitors. So with serotonin, it affects the serotonin receptor, so it blocks reuptake, and so there's serotonin pooling, which causes the antidepressant effect. With bupropion, it blocks norepinephrine and dopamine, so there's pooling of norepinephrine and dopamine in the synapse. So because the hypothesis for depression is, again, involves many neurotransmitters, it's unclear if it's the depletion of dopamine that's causing the depression. Interestingly, bupropion is also an alpha-3 beta-4 nicotinic agonist. So it's very helpful in nicotine cessation. If you have, say, a patient who is smoking, you've tried nicotine gum, you've tried nicotine patch, it's still not helping, you could try bupropion, and it's shown a lot of success with smoking cessation. Some of the adverse effects to keep in mind is that it lowers the seizure threshold. So if you have a patient who's on clozapine, which also lowers the seizure threshold, you might want to be mindful before you add something like bupropion. Just like other antidepressants, it has an increased risk of suicide. But again, it's not the medication itself, it's because of the pre-existing thought. Something to be mindful of is that bupropion does not cause weight gain, and it does not cause sexual dysfunction. So a lot of patients might actually prefer to be on bupropion. Something, again, it's contraindicated in one psychiatric diagnosis, and that is anorexia. So if a patient has an eating disorder, you don't want to give them bupropion because that can worsen their anorexia. It can worsen an eating disorder. So that's something, again, to be mindful of. Then you have your second class of medication, now this is fourth class of medications, which is monoamine oxidase inhibitors. Now, these medications used to be used much before SSRIs and SNRIs. These are older medications. If you look at these diagrams on the slide, they act on all 3 neurotransmitters that are responsible for depression. So they act on serotonin on the first, the diagram on your left, and on the diagram on your right, you can see how they act on dopamine and noradrenaline. So what does the MAOI do? So you take the MAOI, it breaks down serotonin. So it goes through the same pathway and it reuptakes the serotonin just like an SSRI. So what it does is it acts on the serotonin receptor transporter, and it reuptakes. So the reuptake pump is one action. The second action is it increases the production of dopamine, and that's through tyrosine. So tyrosine, if you all remember biochemistry, it's one of those amino acids in our bodies, and it's useful in the production of dopamine. So MAOIs act on that. And the third thing that it does is it metabolizes dopamine. So as a result of this, you're having increased serotonin, you're having increased dopamine, and you're having increased norepinephrine. So some examples of MAOIs are phenelazine and chinylcypromine isocarboxazid. And there are certain specific MAO-B inhibitors, that's selegiline. That's one of the medications used to treat Parkinson's. And you might wonder why, but the reason is quite clear. It's because of its effect on dopamine. And Parkinson is because of dopamine dysregulation. So MAOIs are really effective for treating depression because it's acting on all these three neurotransmitter systems. And as a result of this, you might wonder, why are we not using MAOIs more than SSRIs and SNRIs? And the main reason is the side effects. MAOIs have very severe side effects, including drowsiness and fatigue, low blood pressure, just like other serotonergic agents, decreased sexual function, and weight gain. And these are very distressing symptoms to have if you're already depressed. Imagine you're depressed about something and you're taking a medication that's making you feel drowsy, that's making you gain weight. It might not really, it's kind of counterproductive. Some other side effects to be mindful of is the cheese effect. So MAOI inhibitors interfere with the breakdown of tyramine. And so what happens is that if you're taking an MAOI, you're already having high tyramine levels. If you take some substance that already has high tyramine, you'll have a hypertensive crisis. So some patients who are on MAO inhibitors, they're on something called a tyramine diet or an MAOI diet. So they have to avoid certain foods like cheese, not any cheese, it's usually aged cheese. They have to avoid alcohol, so they have to avoid wine. They have to avoid fermented foods like pickles. But if they keep it well controlled, then it shouldn't be a problem. Because of such an increase in serotonin, MAOIs also interact with other drugs. Like if you give an MAOI with an SSRI, you have to be very mindful that you're not precipitating serotonin syndrome. Serotonin syndrome is another psychiatric emergency. So if you give two medications that have high serotonergic activity, it can result in serotonin syndrome, which causes muscle rigidity, fever, and seizures. That's another reason why. So that's another reason why you don't really augment MAOIs with SSRIs. You have to be very mindful of such things. And the other thing is pain medications and SSRIs should be avoided. So that was our fourth class of medications. Our fifth class is tricyclic antidepressants. So again, very similar to MAOIs. These classes of drugs all act on three neurotransmitters. So just like MAOIs, tricyclics are very useful in treatment of depression. But again, you're not using it frequently because of the side effect profile. So what do tricyclics do? These inhibit the reuptake of all three: serotonin, norepinephrine, dopamine. And so they act on the transporter and they slow the reuptake, and they cause downregulation of the postsynaptic receptors. So what does that do? If the postsynaptic receptors are being downregulated, they're not going to be reuptake. So it's doing two things: slowing the reuptake and downregulating. The TCAs, just like SSRIs, act on this human serotonin receptor transporter. Some examples of TCAs are amitriptyline, desipramine, doxepin, imipramine, nortriptyline, protriptyline, trimipramine. Because of, again, in the past, MAOIs, tricyclics used to be very commonly used, now not as much. SSRIs were first introduced into the market in the 1980s, and now they've kind of taken over all treatment for depression. The side effects of TCAs are mostly because of the different receptors it acts on. So it's an antagonist at many different areas. So think of M1, H1, alpha. And what that does is the M1 is all the anticholinergic side effects. Your H1 antagonism will cause all the sedation. Think of yourself when you take a cold, when you take an antihistamine, what happens to you? You feel sedated, drowsy. The alpha receptor antagonism causes the autonomic instability. One very important side effect to remember with TCAs is that they can cause arrhythmias. So again, one thing to be mindful. A lot of psychiatric medications require baseline ECG before you start the medication, and TCAs is one of them to be mindful of. It causes 5-HT2 receptor antagonism. So that's what causes the weight gain. Some other side effects, TCAs can cause cardiotoxicity. So that slows the cardiac conduction, another reason to be mindful. And TCAs, I told you, right, there are two mechanisms of action. One is it's blocking the reuptake and it's down-regulating the postsynaptic receptor. So you're going to have such high levels of serotonin, dopamine, and norepinephrine that you have to be mindful that someone doesn't have a pre-existing bipolar disorder or pre-existing mania. So that's, again, a reason why history taking is so important in psychiatry, because if you don't elicit this past history and you start somebody on a TCA, they'll have a manic episode. Then you have your tetracyclic antidepressants. So the reason they're different from tricyclic is because the chemical structures are literally a tricycle, and in a tetracyclic antidepressant, it's a tetracycle. Some examples are mirtazapine, vilazodone, trazodone. These don't do anything with reuptake inhibition. What they do is they antagonize certain receptors. So that's alpha-2, histamine, and different serotonin receptors. So they don't cause reuptake, but they do cause antagonism. So again, there's slight pooling of those neurotransmitters in the synaptic cleft. Mirtazapine is a very commonly used medication. It's used to augment certain antidepressants, and it's also used for treatment of atypical depression. So what's the difference between atypical and typical depression? Typical depression will have your low appetite, poor sleep, fatigue, they're not sleeping. But atypical, they'll have increased appetite and increased more sleep. So you want to make sure you're not giving mirtazapine for those patients. Again, mirtazapine is used for older patients who might have trouble sleeping, might have trouble eating. Again, it's useful for patients who have such problems. So again, to review antidepressants, first line SSRIs, SNRIs, you have your MAOIs and your tricyclics. Your MAOIs and tricyclics are usually second or third line, but they're very effective in treatment of depression. So they can be used for treatment-resistant depression. You might want to try them on an MAOI or a TCA before you move on to ECT, which is the ultimate treatment for treatment-resistant depression. So think about it this way: SSRI, SNRI. If that doesn't work, you can try bupropion. If that doesn't work, you can try an MAOI or a tricyclic. If you try an MAOI or tricyclic, be mindful of the side effects. And the last one is tetracyclic, like mirtazapine, which can be used to augment different other medications. Then you have your mood stabilizers. What are mood stabilizers used to treat? Mood stabilizers are used to treat mania. Mania is a presentation in bipolar disorder. You can also see mania as part of schizoaffective disorder. Sometimes mood stabilizers are used to treat certain personality disorders where you have a little bit of irritability, emotional dysregulation. Certain mood stabilizers can even be used to treat treatment-resistant depression, like lithium. Lithium is useful in treating treatment-resistant depression. If you look at the classification of mood stabilizers, they can be divided into lithium, which is a class by itself. You have your anticonvulsants, which includes carbamazepine, divalproex, lamotrigine, topiramate, and gabapentin. Your atypical antipsychotics, which is all these on the slide, and your benzodiazepines. The most commonly used are lithium and divalproex. Atypical antipsychotics also very commonly used. Want to highlight this combination of olanzapine and fluoxetine, which is again it's a very good combination for treatment of bipolar disorder. And you have your benzodiazepines. You want to be mindful with benzos because they have a high addictive potential. So maybe when you give a benzodiazepine, it can be when someone is acutely manic. You've started them on a mood stabilizer, they're not improving. Then you start them on an antipsychotic, they're still not improving. Then you might want to give benzos for a while in the hospital so that they to break their mania. But typically you'd want to discharge patients without benzodiazepines because of the addiction potential. What happens if you give all three? the mood stabilizer, the antipsychotic, and the benzodiazepine, and they're still not getting better, then you can add on another mood stabilizer, so another anticonvulsant. So if you look at lithium, again, its mechanism of action is not fully understood. But if you think of it in two ways, it inhibits excitatory neurotransmitter and promotes inhibitory neurotransmission. And thinking of it that way might help you think of why it's used to treat mania, because in mania, there's so much elevation, so much expansion. So if it's inhibiting the excitatory neurotransmitters, it's inhibiting the mania. And if it's promoting inhibition, again, it's inhibiting the mania. Lithium acts on 3 different neurotransmitters. It acts on the dopamine receptor, it acts on the NMDA receptor, and it acts on the GABA receptor. So when it acts on the dopamine receptor, it modulates its neurotransmission and it decreases the dopamine in the cleft. So that causes the decrease in mania when you use lithium. NMDA receptors. So you remember how we spoke about NMDA receptors with schizophrenia and how it can cause negative symptoms. So lithium, what it does is it downregulates the NMDA receptors to improve the manic symptoms. And it acts on the GABA receptors. GABA is an inhibitory neurotransmitter, so it promotes that. So that helps in reduction of the mania. If you think of lithium side effects, this is a good mnemonic to remember. So L is for levels. It's important to get levels about once a year, at least once a year. Some patients might require more frequently. The maintenance dose is 0.6 to 1. I stands for increased urination. So lithium can cause, it can affect your kidneys and causes polyuria. Because of that, it can make people thirsty. Lithium toxicity can cause tremors. So if you see a patient who has lithium toxicity, what's pathognomonic for it is tremors. Lithium affects your thyroid gland, so it can cause hypothyroidism and hair thinning. Hair thinning is one of the sequelae of hypothyroidism. Be mindful of what other medications the patient's on when they're on lithium, because they can interact with NSAIDs, ACI inhibitors, and diuretics. That's because of the action on the nephron. It acts on the collecting duct, and these are where other medications are also either getting excreted or reabsorbed into the body. It can cause an upset stomach, it can cause muscle weakness and skin effects. So again, if you're getting blood work for a patient with lithium, you want to get a complete blood count, you want to get a thyroid function, and you definitely want to get a renal function. If you look at, so that was lithium, and again, indications for lithium are treatment of mania and sometimes to augment for treatment-resistant depression. Now, if you look at anticonvulsants as mood stabilizers, the commonly used ones are valproate. However, carbamazepine and lamotrigine are also commonly used. If you just follow this key, the blue boxes are all the pathophysiology, the purple boxes are mechanism, the green boxes are the signs, symptoms, the pink boxes are the complications. The reason why anticonvulsants are used as mood stabilizers is because they act on glutamate and GABA. So when they act on glutamate and GABA, they inhibit dopaminergic activity. What happens if you inhibit dopaminergic activity? You're breaking the mania. So you can remember it that way. It also causes blockage of this VSSCs. What are VSSCs? They're the voltage sensitive sodium channels. And what does that do? That causes neurological effects and systemic effects. The neurological effects is it causes some sedation, and as a result of the neurological effects, you can see the side effects of anticonvulsants when they're being used to treat mania. So some common side effects, you can see that it can cause drowsiness, dry mouth, sedation, hyponatremia, nausea, vomiting, diarrhea, liver disease. So when you initiate someone on, say, sodium valproate, you might want to get a complete blood count because it can even cause thrombocytopenia. I don't know if it's mentioned here, but that's one of the effects. You want to get a liver function to make sure there's no the patient doesn't have a pre-existing liver disease. You want to get a basic metabolic panel, which includes a renal function. And sometimes if a patient's too sedated, you might even want to get an ammonia level because of its effects on the liver, it can cause hyperammonemia. So you want to make sure they don't have high ammonia levels. So that's the use of anticonvulsants. Like I said, valproate is the most commonly used. You can use carbamazepine and lamotrigine as well. The other classes of mood stabilizers, so atypical antipsychotics, we already kind of spoke about, but they're very good medications to give when someone is acutely manic. Some patients might even require to be on an atypical antipsychotics as maintenance treatment. And benzodiazepines, we know the mechanism of action, it acts on GABA. That's one of the reasons why it breaks the mania. But again, you want to try to not make sure that they're on long-term treatment with benzodiazepines. Then we have anxiolytics. Anxiety, it's such a commonly seen illness, especially nowadays people are busy, stressed, and so it's very important to learn how to treat anxiety. The first line medication for treatment of anxiety is again SSRIs, SNRIs. Why do people become anxious? What is the cause of anxiety? What neurotransmitter is causing it? It's serotonin mostly. So that's the reason why SSRIs and SNRIs can be useful. Second line drugs for treatment of anxiolytics are benzodiazepines, MAO inhibitors, beta blockers, and buspirone. Benzodiazepines, they act on the GABA. So that's what causes decrease, like that calming effect. If you think about the mechanism of action of benzodiazepines, it's very similar to alcohol. So that's why people who have social anxiety are so prone to drinking alcohol. And that's another reason why you might want to be mindful when you're prescribing a benzodiazepine, because if someone's so anxious and they're going to keep taking the benzo when they feel anxious, they're going to become dependent on it. MAOIs, again, good medications, but a lot of side effects. So again, be mindful. Beta blockers. So typically beta blockers are used for performance anxiety. And what's the mechanism of action of that? So it mimics, so it acts on the adrenergic system, right? So it mimics what happens to your body when it calms down. So it causes slow heart rate, decreased blood pressure. So that it causes that feeling of calmness through the physical effects of a beta blocker and not so much on the neurotransmitters. And buspirone is an interesting medication that we'll get to. So benzodiazepines, like I said, it binds to the GABA A receptor at different sites. So benzodiazepines, barbiturates, alcohol, all act on GABA receptors. Benzodiazepine increase the frequency of opening of the chloride channel of the GABA receptor. That causes membrane hyperpolarization and CNS depression. So again, what are things to be mindful when there's CNS depression? That can cause respiratory depression as well. So again, something to keep in mind. Yeah. So we spoke about, we spoke about the benzos, we spoke about the beta blockers. Now buspirone. Buspirone is another medication for anxiety. It acts as a partial agonist at the serotonin receptor. So what it does is when it acts on the receptor, it's presynaptically inhibiting serotonin release. So the presynaptic inhibition is what's creating more serotonin in the neuron. Some side effects of buspirone is it can cause nausea, dizziness, headaches, nervousness, or excitement. It's not really a first-line medication. Typically, you can prescribe it as 2 or 3 times a day. It can also be used for like short-term relief of anxiety. The last class of medications that I wanted to talk about was stimulants. ADHD, again, a very prevalent diagnosis. In certain parts of the world, it's overdiagnosed. In certain parts of the world, it's underdiagnosed. But essentially, 3 classes of medications that are used to treat ADHD. One is Adderall, so the amphetamine salts, then methylphenidate, which is another stimulant. So those are the stimulants. You can also try non-stimulants like alpha agonists like guanfacine and clonidine, and atomoxetine, which is another medication. So why is it that stimulants, so again, in psychiatry, sometimes medications take a long time to work. But with stimulants, you might see an immediate improvement. And you have a 6-year-old who has ADHD, give them a stimulant, in a week, the parents are going to tell you that they're better. And what's the reason? So stimulant, it's increasing dopamine, norepinephrine, and serotonin in the brain. And as a result of that, the dopamine is increasing the alertness, the norepinephrine is increasing the concentration, and serotonin is increasing the satisfaction. So all the symptoms of ADHD, which is inattention, difficulty concentrating, a lot of hyperactivity, it's improved with stimulants. Here's the mechanism of action of stimulants versus atomoxetine. So stimulants are acting on two receptors. They're acting on the dopamine reuptake pump and the norepinephrine reuptake pump. As a result of that, stimulants are more effective. They're causing more pooling of neurotransmitters in the synapse. Atomoxetine is acting only on one reuptake pump. That's the norepinephrine reuptake pump. So not as effective as stimulants, but if you're concerned about addiction issues, or if you think that maybe you want to try atomoxetine first, that's something to consider. Side effects. Now, if we look at Adderall side effects, or that's amphetamines, think of somebody who is on a stimulant, like a drug, like MDMA or something like that, and think of some of the things that you might see with them. Certain things, when you're especially giving an adolescent or somebody in their late teens, you might want to make sure that they don't have a pre-existing mental illness, specifically bipolar disorder, because it can worsen that. So other things that you might see is people might feel irritable, agitated, hostile. In kids, you want to monitor their weight because they have decreased appetite. So again, some of those things you want to be mindful of. Methylphenidate, similar to amphetamines, but the way you can conceptualize it is amphetamines are similar to MDMA, and methylphenidate is actually similar to cocaine. So basically, again, you want to make sure there's no autonomic instability, the appetite, stomach problems. You want to get a good psychiatric history. Atomoxetine and alpha agonists in general have fewer side effects. With alpha agonists, you want to make sure you get baseline blood pressure readings because they can act on the blood pressure, they can act on the heart rate. Again, it can cause irritability, constipation. Atomoxetine has much fewer side effects, but mostly nervousness, sleep problems, fatigue, etc. So those were basically the medications that we discussed. So we discussed antipsychotics, antidepressants, mood stabilizers, anxiolytics, and stimulants. I wanted to briefly touch upon certain other treatments like electroconvulsive therapy. It's become they've shown a lot of ECT in pop culture where they kind of villainize it and make it look really barbaric. But the reality is ECT can help a lot of patients, and it's very useful in the treatment of treatment-resistant depression. It's very useful for patients who are pregnant and who are not responding well to antipsychotics, mood stabilizers. It doesn't have any effect on the fetus. So I encourage you, if you're in practice, to advocate for ECT being used. It can really cause a lot of benefits for patients. Again, in TV and in movies, they might show ECT as a really barbaric procedure, but this usually happens under anesthesia. So what happens is they place the electrodes on the side, you're completely sedated, and they deliver 2 to 3 shocks, which induces a seizure. But because you're under anesthesia, your whole body is not seizing. So it's just your leg that's essentially seizing. ECT reportedly rewires your brain, and that's what helps with the treatment of the depression, helps with psychosis, helps with mania. Other newer interventions, there's transcranial magnetic stimulation, which is similar to ECT. Again, it resets your brain. Vagal nerve stimulation, they're trying that out. So they essentially stimulate the vagus nerve, again, to reset the brain. They're trying it for treatment of depression and mania. And deep brain stimulation, they're trying that for treatment of OCD. So again, lots of new innovations in psychiatry. And that's basically biological therapies. Thank you all. I hope you found that useful. If you have any questions, I'm more than happy to answer some of them.
Um, I would like to thank Dr. Natasha for a very insightful lecture. The topic was a pretty difficult one because it involved all the therapies in psychiatry and a large number of drugs. And I don't think it's possible to explain all of it in 40 minutes, but I think she did a very good job. And I would like to tell her a bit about our foundation. We do a lot of work in regards to mental health in India. That is, along with organizing these webinars and lectures, we do a lot of camps on ground in different parts of India where we treat patients. We're also opening up a psychology college where we're going to start MPhil and MSc courses. And we also do some relief work. I do have one question to you. That is about the chart which you were showing about, I think, carbamazepine and lithium, and you explained something about, some effect which I did not get. I think I have also. I think it is about the. If you could just explain that part, I think it is about the carbamazepine lithium chart which you did. So if you could just explain that a bit more, because I think some of us missed that.
Is this the one?
I think if you can go back, I think
Are you able to see my screen?
no, we can't. I don't think we can see a screen. I think
Oh.
I think the chart was, you mentioned something about lithium and the down regulation which lithium does and carbamazepine does. So I think I think this is the chart. Yes, right.
This
So I
is the
think
one.
if you can explain this, yeah, right, right. Yes. So if you
So,
can just explain this chart, yes.
so if you think so, lithium and anticonvulsants, they both act in different ways. If you think of anticonvulsants, they all essentially act through sodium channels. So if you think of your brain, you have your sodium channel, and that's what it's acting through. They block the sodium channels in your brain, majority of the sodium channels. And they also block calcium channels. That's how it stops the seizure, because it's blocking that electric activity. What happens when you block the sodium channel is the sodium channel it regulates glutamate and GABA. So it decreases glutamate and it increases GABA. GABA is an inhibitory neurotransmitter. So by increasing GABA, it's decreasing mania because it's causing the depression. And it's decreasing glutamate, as a result of which it's decreasing dopamine, which is then decreasing mania. So that's through the sodium channels. Through the calcium channels, now, if you think of calcium, you think neurological effects, right? Because if someone is hypercalcemic, they have all these neurological, you'll have the spasms, you'll have all these neurological phenomena. So calcium channel blockade leads to neurological effects. So the neurological effects of these anticonvulsants are sedation, essentially. And the systemic effects of calcium blockage is what causes the nausea, vomiting, diarrhea, hyponatremia. But from a psychiatric standpoint, it acts on two channels, sodium, calcium. Sodium affects glutamate and GABA. Calcium causes neurological and systemic effects.
Yeah. Okay. Thank you so much. I think this chart is very interesting because I've never studied this in my residency, and it really compares both the side effects and the mechanism of action. Now I would request Dr. Nyogi to say a few words and give her a motion of thanks, if possible. So requesting Dr. Nyogi, Rajashri Nyogi, uh, uh, Assistant Professor, Arjikar Medical College, to give a few words. He can give some comments on the topic itself if he wishes to.
Thank you so much, CAV and Boidonath. And may I share a secret with Rachel? So Boidonath was I have been a mentor to Boidonath, and he has been doing pretty cool stuff from then. I don't credit myself for that. And this CAV is his brainchild, and wherein he moved from a typical NGO to maybe more into advocacy in psychiatry, advocacy in mental health research also. We are, and Boidonath, I'm happy and glad to share that Boidonath is doing a research on COVID encephalopathy and neuropsychiatric manifestations in COVID from one of the spear hospitals. So this is a bit about Vijayanath and CAV's background, and of course, people from CAV are helping out in data collection and other things as well as for the relief work. Coming into the topic, well, fantastic, because I haven't seen, haven't had been seeing such a good lecture, such a huge amount of data packed into one nice lecture, not data overloading, but then going with the flow, and also covering almost all the points. I mean, all the points, all the boundary points, all the points, and your charts and visuals were great. The cartoons, the charts, the flow diagrams were great. Thank you for this very wonderful and enlightening lecture. And I wish that my students actually emulate you. We don't have many of my students in this forum. Some have joined. I can see. So they emulate your skills, and it's really great to hear from you. I would love also to hear from you again. Maybe some other time, some other lecture, some other topic, maybe some advances into psychiatry and something like that. Or maybe we can discuss about how psychiatry is being done in USA and in UK. Have a couple of friends there also who have learned psychiatry from PGI. I am from PGI Chandigarh. I did my MD from PGI Chandigarh. And some of my friends moved from PGI to the US, did their residency again, and have been practicing there. So it's very interesting crosstalk. So maybe sometime we can talk about that. Thank you so much for sharing this wonderful evening with us, and this had been a very wonderful evening for us. And I suppose that your evening is just starting off. I mean, it will start off after the afternoon. So have a great weekend, and thanks for being with us and being with you.
Thank you for having me. I had such a great time preparing and presenting, and truly an honor to present. Thank you so much.
Thank you.